So past medical history, he is a polysubstance user, alcohol abuser, has cirrhosis, hepatitis, asthma, heart failure, and seizure disorder. So eye exam, his right eye is light perception, left eye is count finger, and I have some pictures of his eye to show you. So this is his eye. You can see cornea here kind of mixed in with uveal tissue and some heme. This nasal view here, a lot of uvea underlying that you see, and heme. The conj is kind of injected also. So B scan of his eye is normal. And here's the anterior segment OCT. So the differential I came up for this patient was a total corneal staphyloma, or a very large just metasteel, which is less likely if you look at the anterior segment OCT. Here it's pretty thickened, and or ocular surface tumor, but given his history, it's less likely. So wanted to talk about acquired anterior staphyloma. Kind of looks like a blueberry eye. So I guess, let me just zoom in. So the cause of this is usually due to a corneal perforation from untreated keratitis or recalcitrant corneal ulcer. You get a perforation and the underlying iris kind of plugs the wound. The iris has vessels, so kind of causes healing and epithelialization over the perved cornea with the formation of a pseudocornea. And the pseudocornea is weaker, so it cannot withstand your normal intraocular pressure, which then leads to gradual protrusion of the eye. And also, if you can imagine, if your iris is kind of stuck to the posterior surface of the cornea, there's kind of narrowing or even closure of your anterior chamber, and even causes further elevation of your pressure. So here's the picture on the right is the picture of our patient. You can see here a little nasal to central cornea. This uveal tissue, likely this area was the initial perforation. Iris plugged here, and then you get this pseudocornea formation and gradual protrusion of the entire weakened cornea. So treatment option for cases like this, you can offer a patient reconstructive keratoplasty if they're interested to improve vision. And so cases like this, the entire cornea is diseased. So if you're planning a penetrating keratoplasty with a very large graft, the surgery becomes pretty complex just because there's no visualization of the anterior chamber. You cannot really tree find this cornea, which is bigger than the limbus. So you have to go freehand and risk high risk damage to your angle structures, which causes high incidence of postoperative glaucoma and subsequent graft rejection. So another method would be sclerokeratoplasty, where you, instead of entering from the limbus, you enter posterior to the limbus at the sclera, and you kind of sclera tunnel the dissection to anteriorly to the limbus, so that when you enter the anterior chamber, you avoid the angle structures. Also, if the patient is not interested in kind of reconstructive procedure, then you can offer them enucleation and evisceration if the eye is painful or for cosmesis reasons. So I wanted to go over sclerokeratoplasty here. The picture on the left is the preparation for the donor graft. You can see it's full thickness cornea with partial thickness sclera. And here, the picture on the right is how you would perform the dissection. First, you do a 360 conjunctival porotomy to expose the underlying sclera. Then you kind of mark about a 14 millimeter annular mark. That's where you will be entering the eye to do your lamellar dissection, about 50% thickness, sclera thickness, and you advance the dissection to just anterior to the limbus, and then you enter the anterior chamber that way. And then afterwards, you we perform blunt dissection or viscodissection to free the underlying iris away from the cornea, and then free the cornea, and you then would transplant the donor graft over. So this is a paper that kind of compared surgical outcome of sclerokeratoplasty versus penetrating keratoplasty in patients with anterior staphyloma. They looked at about 20 eyes. 10 eyes had sclerokeratoplasty, another 10 had penetrating keratoplasty. Here you can see the table on the left. None of the patient in the sclerokeratoplasty group had elevated intraocular pressure, and about 50%, 5 out of 10 patients in the PK group had elevated IOP. Table on the right, here you can see patients in the sclerokeratoplasty group had better visual acuity outcome at 1 year follow-up compared to the total penetrating keratoplasty group. Here, table on the left is showing graft clarity. 4+ is clear graft, and as the number decreases, the hazier the graft gets. And here again, in the sclerokeratoplasty group, the graft were more clear than the penetrating keratoplasty group. This is another paper that proposes slightly different surgical technique for these patients. Instead of sclerokeratoplasty, they performed total penetrating keratoplasty, freehand trephine from the limbus. But what they did differently here is in all of their patients, I think 8 patients in this paper, they performed cyclodialysis cleft for these patients just to prevent post-operative glaucoma. And here they, before trephining, they entered eyes in the central area to kind of perform some dissection first to free up the iris from the cornea. And here in the 8 patients, the 8 eyes that they had, all of the patients had normal intraocular pressure, and about 7 out of the 8 patients had pretty clear graft. Maybe just 1 other patient had only 2+ kind of hazy graft, but most of them did well in either 6 or 12 months follow-up, and their vision was pretty good. So for our patient, we kind of followed him for about 3 or 4 weeks or so since presentation. He developed progressive pain due to further elevation of his intraocular pressure and also inferior exposure, a P defect just from the lid not covering the staphyloma completely. We offered him the option of anterior segment reconstruction versus enucleation or evisceration, but patient was just not motivated. He's still very non-compliant and doesn't really follow up as instructed. So he elected for temporary tostography followed by enucleation. So this is how his eye looked like at the time of surgery. You can see this anterior staphyloma is pretty big. So this is some pathology slides to share with you. Here is total limbus involving with total protrusion of your cornea. Here's the pathology report. The entire cornea shows scar tissue with neovascularization, chronic inflammation. You see some decimate kind of mixed in with scarring, and epithelium is continuous, shows squamous metaplasia. Interior aspect covered by uveal tissue, HSV is negative. So here's more pathology slide. Here you can see ciliary bodies, limbus is right here, and total forward movement of the iris opposed to the posterior cornea. Here a lot of inflammatory cells, neovascularization, thickened cornea. Here the other side of the limbus also involved.